Welcome to Project Echo. Today is the fourth training in our current group of four. Ed's doing a talk on Kratom, Xylazine, and Tianeptine. Couple housekeeping things. Again, no one involved in these trainings have any financial relationships to disclose. Usual funding statement: we're funded by a federal grant. The state opioid response grant comes to us through Nebraska DHHS. Usual process for CME certificate. I will drop a link in the chat today. I'll also get a link out in an email by the end of the morning today. Just do a quick survey and your certificate will pop right up. So we do these in groups of four. And this is the fourth of the four trainings. So we'll be off next month planning for the next series. The first three trainings we've done in this cycle have been focused on pain topics. Now we're kind of switching over to some substance use stuff. So Ed's talk is a good transition into our next series, which will be in July and August. So we've got Ed, Gail, and Stephanie doing talks on alcohol, cannabis, and methamphetamine use disorder. And there's a link, or there's a question in the evaluation survey. If you want to register for this, you can just click yes in that evaluation survey, and you will be automatically registered for this next cycle of treatments if you choose. So even though we'll be off for a little over a month now, the consultations are still available anytime. And again, the best way to do that is just to contact me and I can hook you up with one of our experts. We've had several of you do that. It can be kind of quick single one-time question things, or it can be kind of a longer engagement of kind of mentoring and such if you need some help with. For example, one of the things Ed's doing now is helping some people prescribe Suboxone, so that might take a few kind of meetings and conversations, and we're happy to do that. We're a grant funded project, and all of our time is covered under the grant through those types of things. And I'm going to let our Echo team introduce themselves. Janet, would you like to go first?
Yeah, I'm Janet Bernard. I'm a retired family practice doctor from North Platte. Used to treat lots of people with Suboxone for opiate use disorder.
Stephanie.
Sorry about that. Stephanie Bennington, psychiatrist, primarily located in Omaha, see patients mostly in hospital and ED settings in several states. Nice to see you all.
And Todd.
Good morning, Todd Stahl. I'm a psychiatrist.
And then let's see.
And
John.
Will, I think John is on.
John is on. Yeah. Hey, John, would you like to introduce yourself?
Hi, guys. Good morning. John Massey. I'm an interventional pain specialist in Lincoln.
And I believe Gail Keller is not on today. So Ed, I'm going to turn it over to you.
All right. Thank you, Will. Good morning, everybody. Ed Kaiser here. I'm a nurse practitioner in Omaha, Nebraska. So I've been working with substance use disorder for the last 6 years for a company that works sort of in multiple states, and so primarily located in Nebraska, but working in other states as well. So can everybody see the screen okay? Give me a thumbs up, Will. Yeah, okay. Excellent. Yeah, so thanks for joining us again. Again, just the reminder on the sort of Project Echo, like our goal is to really just be a helpful resource for people. And so I'm going to kind of go through a talk this morning talking about some of the substances that are out there just to help you get more familiar with them if you're not. But also just want to encourage you, hey, drop questions in the chat, case studies in the chat as well. And if you missed any of the first three talks, those were super good. Dr. Massey and Dr. Stoll did a really good job of, talking about pain and micro-initiation and sort of complex patients. And so I really enjoy listening to those guys every time they do a presentation. I learn a lot. So really want to encourage you to watch the recordings if you haven't already. So yeah, we'll go through these three topics this morning, and then I do have a couple of case studies set up for us. But again, put some questions in the chat or case studies. We'll have time to do that at the end. So we're going to talk about Tianeptine. You may or may not have heard of this. It's sometimes referred to as gas station heroin. We're also going to talk a little bit about xylazine today, which has been referred to as the tranq dope. And then I want to spend probably the majority of our time in case studies on kratom today. I couldn't find a fancy name for kratom. It's sometimes referred to as a herbal speedball, but really you'll see kratom signs all over the place, especially at like different smoke shops or gas stations. So here's the learning outcomes. I'm really just trying to help you have a better understanding of these substances that are being used on the street. If a patient comes to you, I want you to be able to discuss the dangers and some of the treatment options that are available. I do want to spend a little bit of time today trying to understand why patients or why individuals may continue to use dangerous substances. Again, addiction and substance use disorder is a complex disease process, so we're not going to really fully tackle that. But I want to discuss like why do people continue to do this, and we'll get into that a little bit later. And then do want to just talk to you about how to initiate Suboxone treatment for individuals who may be using these substances, and again, more specifically towards the kratom. So the agenda will be pretty straightforward. We'll just go through each of these topics, and then we'll do the case studies together. All right, so here's a picture of, Tianeptine or the gas station heroin. I honestly have not actually seen this locally. Not that I've gone looking for it, but it is something that's out there. There was a patient that we saw just the other day. We had like a consult line with our team, and someone had reached out saying, hey, I have a patient who's using Tianeptine. How do I start them, on Suboxone? So it is out there, but maybe not super prevalent, at least where we're at in Nebraska. So Tianeptine is it's a drug that's been around for a long time. It was initially a tricyclic antidepressant that was approved for treatment of depression. Initially, I think it was in France and in Europe and some other Latin American countries, but it's never been approved for treatment in the United States. So it's a atypical sort of opiate agonist. Try to get my screen to fit there. It's got a relatively short half-life, maybe 2.5 hours. Just to give you an idea, a prescription dose of Tianeptine is closer to like 12.5 milligrams 3 times a day, where when people are using it on the street, it's closer to 500 or 3,000 milligrams. It can be injected, but most of the time we would see patients taking this orally just as a free base. Interestingly, to me anyway, so where states have outlawed kratom or have restricted it, we've seen an increase in Tianeptine sales and like calls to poison control and stuff like that. So again, kratom may be more prevalent than Tianeptine, but it is out there. And then as you try to cut down or stop one substance from being out there, different ones pop up. And so I just found that interesting that the states that don't have kratom have an increase in Tianeptine. So we talked about just gas station is kind of where you can get it and sold online. One of the ways that the Tianeptine is purchased is through the online sort of websites or whatever. And the way they get around this is they say that they're using the supplement for either for research or some sort of like dietary supplement. And so a lot of like the designer benzos and different things like that you can buy online are similar in that you can circumvent sort of the US drug laws and buy or purchase or sell those by saying that you're just doing research on them. So again, Tianeptine never has been approved in the U.S. for the Food and Drug Administration for medical use. The marketing for it, they're making these claims that it can improve your brain function, it can treat anxiety or depression and pain, and also that it, can even treat opiate use disorder. And so again, it is a atypical agonist for opiates. So some patients who have gotten started on opiates or dependent on opiates could use Tianeptine if they couldn't have access to other things. But again, the claims on this sound good, but they obviously can be pretty dangerous as well. This data is a little bit old. It's from 2000 to 2013, but it did talk about Poison Control Center involving Tianeptine cases had been on the rise a little bit. There are some studies that show that, or case reports, I guess, that show there's been some fatalities with Tianeptine. Not super common for that to happen. And then again, the effects of Tianeptine from the CDC, essentially it's just really similar to opiates. So you're going to have similar withdrawals that mimic opiate toxicity. for patients that are using or abusing tianeptine long term. So because it acts like an opiate, the first line thing we always want to talk about. I mean, I used to be working in the ER, and so I'm always thinking about what's the thing I need to know to save the patient's life. And so Narcan, it can be used in these situations. We obviously are trying to make Narcan available to more and more people, but if somebody is having an overdose from the tianeptine, you can use the Narcan to overcome that. This is just another study that talks about, chronic use represents opiate use disorder, impaired control, impaired function. You can develop tolerance and withdrawals, all of which are similar with opiate use. And then again, just that it's appropriate to consider medications for opiate use disorder for the management of tianeptine use disorder. So again, I'm a Suboxone guy. I've been using Suboxone for a long time, but methadone is also an option for treating patients who are struggling with this disease process. Here's just a quick kind of summary slide for you. Again, just a couple of the bullet points. Tianeptine can create opiate use disorder, like any opiate can. Buprenorphine is safe and effective for stabilizing tianeptine use disorder. Generally, for patients who come in with like a tianeptine use, we're going to use what we call like a conventional initiation process with them. The conventional initiation, we generally are going to go, have them wait maybe 24 hours from the last use, or some of the newer studies on that, at least from ASAM, the people that were in it this most recent time from our company that went there, was just saying like, hey, we're trying to wait 24 hours from the last use of a lot of these opiates, but really symptomatic initiation may be the best model. So wait maybe 24 hours or until patients are having significant withdrawals, physical signs of withdrawals, which could be like, dilated pupils or sweating or nausea, vomiting, and then having them initiate on the medication at that time. So for different individuals, they metabolize the medication differently. But generally, conventional initiation will start with a small amount. Suboxone usually comes in an 8 milligram or 2 milligram. You're going to do 1 to 2 milligram increments every like 60, 90 minutes. I generally want to prescribe enough medication so that patients are not going to still be in withdrawal. So I may prescribe up to 12 milligrams initially, but I can tell patients, hey, you don't have to take the full amount of 12 milligrams. You can stop at 6 milligrams or 8 milligrams if you're feeling well. So conventional initiation is generally what I recommend. Again, Narcan reverses it. And then because the tianeptine is an atypical antidepressant, we're going to make sure that we monitor these patients for anxiety and depression and refer or treat them appropriately. Again, these slides are available to you. This is the slide that we use as a patient-facing handout. It talks about sort of a conventional initiation method, which I've sort of already gone over. But in this, it says step 2, start with 2 milligrams. You can, again, use less than that. You don't have to use a 2 milligram. You can use 1 milligram. I do want to highlight some of the withdrawal medications that we'll often use at the bottom, like clonidine, Vistaril, Zofran, even sometimes gabapentin. Generally can be helpful. Patients can take those in the first 24 hours, and they can take them as they've already initiated onto the Suboxone as well. I do recommend, and we always prescribe Narcan to all of our patients. Again, the reason behind prescribing the Narcan for someone with opiate use disorder specifically is not that we're concerned that prescribing the Suboxone is going to cause them an overdose. But the concern is if a child or somebody who's never used opiates before got a hold of Suboxone, that theoretically could cause an overdose in a child. So we're always telling patients, hey, make sure you're keeping your medication locked up. Make sure you have Narcan at home. Make sure all the adults know it's available. And if, God forbid that would happen, you're going to want to tell them, give the Narcan and call 911 right away. So I just think it's a good practice to prescribe the Narcan for patients. All right, so that's tianeptine. We're going to transition into xylazine. I'm not really monitoring the chat, so if there are questions individually on those things, we can stop at each section and answer them. But if not,
I'll keep an eye on it, Ed. I have already answered one.
Okay, excellent. Thank you, Janet. All right, so let's transition now. Let's talk for a few minutes about xylazine. So you may or may not have heard of xylazine. It's caught a lot of attention in the news, maybe in the last couple of years. But xylazine essentially is a non-opiate sedative. It's commonly used in procedural sedation in veterinary medicine. It's essentially like an alpha-2 agonist, similar like to clonidine. And again, xylazine was never approved in the US by the Food and Drug Administration in humans because in clinical trials, surprisingly, not surprisingly, it caused severe central nervous system depression and sedation, right? So that's exactly what we see in patients who are using xylazine laced substances. So again, xylazine primarily is not used on its own, but we see it as an additive in the unregulated drug supply. It's been found to be mixed or laced with other substances, but most commonly we are seeing it in the illicit fentanyl drug supply. So initially, xylazine was first seen in Puerto Rico in the early 2000s, and then it began appearing in like Philadelphia, and has spread in the Northeast and also westward and southward. It's not exactly sure how, when, or where it's being added to the drug supply. And again, sometimes it's referred to as the trank or the trank dope. The company I work for, again, we do definitive drug testing. And within the last 2 years, we've had the ability to actually test for xylazine in the patients that we're seeing, which we didn't have that technology a couple of years ago. And the drug testing that we do, we sort of make it available to the public because we want people to know, like, hey, people are taking their medicine and there's where the drug supply is. And to whoever it could be helpful for, we like sort of take away all of the patient information and just make that available. And so very similar to what we're seeing in the research is like, yeah, up in like Maryland area, we see a lot more, sometimes in Washington. I have seen some xylazine in like Montana, North Dakota, but definitely not as much as what we're seeing on the coast. So again, the effects of xylazine, similar to what we've found in studies, but it causes this really deep sedation and sort of heavy, nodding out, especially in the first 20 to 30 minutes, depending on the route of administration. If people are injecting the fentanyl with the xylazine. People can actually be sedated for several hours. And then again, this obviously puts them at significant risk for physical or sexual assault, medical complications that can happen from sort of laying in place for too long. And then again, the biggest concern with the xylazine is overdose. When we talk about when you're adding substances that are sedating, or a combination of them, the concern is central nervous system depression and then respiratory depression. So there actually can be a physical dependence and withdrawal that happens for someone who's only using xylazine or primarily maybe getting a lot of xylazine in what they're using. And people can develop withdrawal symptoms. Withdrawal symptoms specifically more associated with the xylazine would just be like anxiety, high blood pressure, increased heart rate, sweating, restlessness, agitation, and irritability. There's not really clear recommendations on sort of the treatment of xylazine withdrawal, but there have been some benefits of using something like clonidine to help with those withdrawal symptoms. Probably the thing that xylazine is known most for is these skin wounds that are associated with patients who are using this. Those skin wounds, initially we thought that they only happened for patients that were injecting xylazine or fentanyl that was laced with the xylazine, but also it can happen in patients who are smoking the fentanyl, where they can actually get the wounds as well. So again, it can happen at the injecting site or other sites. I do have a slide here coming up. This is just like your pre-warning. I know y'all are medical professionals, but the slide is a little bit gross, showing a few of the wounds. So you have been warned if you want to look away. So when you see the bottom left here, like this is what the wound sort of starts to look like as a patient begins to get these sores from the xylazine use, and then it sort of progresses into what you see in some of the other pictures with sort of this like big open gaping wounds, and then the sort of the necrotic tissue that's there. So if you search online for xylazine wounds, you're going to see these pictures and many more, and they're really, really pretty sad to see how devastating this disease process can be. So at this point is when I want to just have a little bit of a discussion with you. It's just like, hey, why would a patient continue to use fentanyl with xylazine, right? Like they have these big gaping wounds. We know that it's super dangerous. There's been lots of overdoses that have been associated with it. And so um, I've written down a couple of thoughts, again, not trying to act like I know all the answers here, but as people get farther into substance use disorder, specifically with opiate use disorder, a lot of times I hear patients that say that they're no longer using the drug to get high, right? They really are just legitimately trying to feel normal and or not feel sick, right? So if a patient is, in a location where they've been using fentanyl for a long time and the only thing available is fentanyl that has been laced with xylazine, like they're going to continue to use what's available to them, even if there are, severe wounds associated with it. Not to mention, when you get into these wounds too, you're dealing with some severe pain and a lot of things like that. And so continuing this cycle of using the fentanyl can be one reason where patients continue to use. I was recently at a PA conference in Kearney with Will. We were doing like a Project Echo booth, and I went and listened to one of the educators talk about sort of substance use in Nebraska and some of the drugs that are being seen and used in Nebraska. It was Lieutenant Eric Kaufman who was given this presentation, and he did this really powerful part of his presentation, which I'll kind of reiterate to you here, but I'm really just stealing it from him. But what he did is he put a picture of a person up on the screen and said, hey, does anybody know who this person is? And nobody knows who it is. It looks like a kind of an old 80s rocker guy with long hair, and so he says, hey, this guy was a really prominent, singer in the Seattle area back in the 80s or 90s. And everyone around there knew that he was one of the up and coming singers. He was part of a really famous band, which I honestly can't even remember the name of the band, but the band went on to be very famous. He was the lead singer, and he was known to be a heroin addict. He had a known heroin sort of use disorder, and in the whole area, everybody knew that. So the story goes, hey, sadly, this guy passed away. He overdosed on heroin pretty early on in his career. And so what people thought was going to happen, because he was really prominent and well known, was sort of that his overdose would wake people up in a way of saying like, hey, this is super dangerous. We need to like maybe try to get better or get help. And the phenomenon that he talked about was actually like just the opposite. Essentially, what happened was people who were using heroin at that time wanted to know who the dealer was that gave this guy the drug that he overdosed on. And so when he talked about like, hey, when people are creating these substances and sending them in and making them more and more potent, Lieutenant Kaufman's point was like, hey, they don't care if someone's going to overdose and die, because it's actually almost good business for them, because that is going to make people who are stuck in this disease process wanting to like either feel that high again or even look for something that's stronger. And so I just thought that was helpful for me as I begin to think about just like how to treat patients and sort of what they're going through, to try to put myself in that mindset. I often talk to patients who are on Suboxone and been in recovery for a while and just ask them, hey, what's better about your life, or what's different than it was? And they just talk about sort of these super dangerous or risky behaviors that they used to do, that they would just say like things I would never do in my sort of quote right mind. And so again, I share that just to say, hey, the early intervention on this stuff is really super important. And so we're sort of talking about xylazine, which is on the far end of it, which a lot of us may never actually see patients who are, using fentanyl with xylazine. But the tianeptine and the kratom, we really want to be encouraging to be, early intervention for those substances before it sort of gets so bad. All right, so here's the xylazine summary. Again, Narcan can be used for overdose. Narcan is not reversing the xylazine in any way, but it is reversing the fentanyl. And so again, xylazine or Narcan, you may need to use more than one of these for patients who are using fentanyl with xylazine, but that's the first line to help prevent overdose. Mentioned that it's more prevalent on the coast, but it's being more and more widespread. Wounds are worse at injection sites, but have been seen with smoking and laced xylazine as well. And then again, as far as the wound care goes, initially there wasn't like clear evidence on what to do, but essentially it's just like we're trying to debride the dead tissue and maintain healthy tissue, and obviously prevent sort of more of like tendon and bone involvement. But there's nothing special beyond that, just kind of debriding that and trying to allow that to heal. Suboxone and methadone both can be used to treat patients with opiate use disorder, even if xylazine is part of the picture as well. All right, so let's transition now and talk a little bit about Kratom, which I want to spend the remainder of our time together this morning sort of highlighting quick objectives related to specifically the Kratom talk that we're doing. All right, so what is Kratom and where does it come from? Essentially, Kratom is it's an herbal extract that comes from the leaves of a tropical tree. I can't exactly pronounce it, but it's there in the slide in Southeast Asia. And it's used to combat fatigue, improve work productivity in workers. And so, you know, everybody's trying to improve their work productivity and help with their fatigue. Excuse me. So how is Kratom used? It comes in a leaf sort of tea is the primary way that you see people do it. It does get put into a pill form, and then finally it will also be found as like a liquid extract. So all of it is taken orally. The low dose Kratom, maybe 1 to 5 grams, has this sort of stimulant effect on individuals. And then as you go into higher doses, you get more of sort of this analgesia and euphoric effect for people. Again, marketing for Kratom sounds great. I mentioned this a little bit earlier, but it's an herbal remedy for, again, opiate withdrawal, pain, fatigue, depression, anxiety. And again, I've seen a handful of patients, probably more than that, but people who maybe used to be either prescribed medications, opiates that is, or have been using opiates that eventually have sort of transitioned into Kratom, thinking that that's like a safer, you know, herbal sort of way of taking care of their withdrawals. And eventually the sort of the same cycle presents where it's just like, it's not enough. They need more and more to sort of start to feel normal. And then they get into some bad side effects from using large amounts of Kratom. I thought this was interesting. I'm not going to read all of these to you, but some of the quotes of people who are actively using Kratom, you know, one of the patients says, like, I felt relaxed and sedated, free of my normal pain, my normal thumb pain and back pain, which I thought would never be possible. And I also felt this sort of nice fuzzy feeling, or which I get when I smoke pot, you know? And so I had a patient that I saw just a couple of weeks ago who had admitted to using IV Dilaudid in a relapse situation. And he told me, the way he described it, he said, it felt like God was giving my soul a hug. And so I was like, oh, that's an interesting perspective on that. But anyways, it gives you the idea of like a little bit of a taste into the mind of like, hey, what are these people? Why are they using it and what are they feeling? So you can read those if you choose. Here's the pharmacokinetics half-life of Kratom. It varies in the literature of what it is. Some say 24 hours, others say 3 hours. I would say, in my experience, it's probably closer to the shorter half-life. The peak in the plasma is 1 to 2 hours after the initial ingestion of the medication. The nice thing about Kratom is overdose is unlikely because the effective dose is about 25 or 20 times less than the lethal dose. So again, when you think of Kratom versus other opiates or fentanyl, it's a much safer drug, although it is still an unregulated drug and one that we don't recommend. In drug screening, when you have the ability to test for Kratom, and especially if you do it on a definitive level, you will see that Kratom does stay in the patient's system for up to like 2 to 4 weeks. Again, it's not really super active in that way, but you will see it positive on drug screens. Here's a slide for you about just sort of the side effects of Kratom. You know, you can have some GI issues with nausea, constipation, vomiting, behavioral issues, sometimes some dizziness, tremors, seizures, urinary symptoms, skin issues. And then again, if you're really really trying to, you can have a acute toxicity and even overdose from Kratom. This slide just gives you a little bit of an idea of sort of what the withdrawal process is like when patients are coming off of Kratom. So in the first, 24 hours or so, patients will get significant sort of anxiety, nausea, body pain, sweats. Then as time goes on, the next 2 to 3 days, increased depression, they start to get these shakes in the withdrawal symptoms and significantly increased Kratoms. And then things continue on past 72 hours where they get the tremors. At the bottom there, it just talks about a smoke shop employee, which again is primarily where you probably would see this sold. Also, you'll see signs around. Once I first learned about Kratom, as I looked around Omaha, felt like everyone was selling Kratom. There were signs everywhere, Kratom sold here. And so this is just a quote that says, hey, people come in with the Kratom shakes, all the time. So just showing like, hey, people are having a physical dependence on this and they're having withdrawal symptoms getting into the, 24 to 72 hours and sort of needing more Kratom to get back to feeling normal. So a few things to know about Kratom. Again, just another sheet for you. This is from SAMHSA. How it affects your brain. Kratom can be addictive, serious side effects. It's an unregulated substance. Again, comes in the teas, tablets, and then the liquid extract. It is important to kind of monitor for lead poisoning and things like that, depending on where the Kratom is grown. And then interestingly, I think in number 7 there, Kratom is banned in the region in which it originated, and it's banned in some states, right? So if we're dealing with a substance where the place where they initially started using it no longer allows it, I think that should give us some direction into why we shouldn't allow it as well. Here's a Kratom legality map. This one might be a little bit old, but it just shows you, hey, there's some states out there where the red ones where it's actually been banned. Some of them have had legislation that has failed to try to get rid of it. And then, the dark green is where it's sort of fully legal. And again, I mentioned this sort of at the get-go, but one of the things that we see happening in those states where we ban Kratom is that we have an increase in other drugs, specifically, the Tianeptine. And so I think that that's an interesting discussion on how we sort of manage it. I think we still need to get rid of it. My personal opinion on all of those sort of like substances that are legal, including like marijuana, I just think that the more legal it is, the more access that kids have to it, and people can get started at an early age. And so I think banning it obviously is the best thing, and I hope that happens. But it also does create other problems because new things show up and people begin to use different substances as well. All right. Let's talk about how to treat Kratom, because you might actually see a patient that comes in who's been using Kratom. So just to be clear, there's no FDA-approved medications for Kratom use disorder. There's no randomized controlled trials at this time, at least that I'm aware of. There are case studies that are available. And so, again, the first line that we talk about is probably motivational interviewing, which we've done some talks on before, but trying to help people kind of get that intrinsic motivation to try to stop. But also OUD medication, Suboxone and methadone can be used to treat Kratom use disorder. So here's a case study. This Dr. Allgaier, who is listed here in this case study, he was one of the docs that sort of initially taught me how to, help patients with substance use disorder and treat substance use disorder. And he actually asked me to be a part of this study, which I totally should have done. I should have jumped on that and put my name on this, but I thought I was too busy at the time. But anyways, I digress. This study was just like, hey, we had patients in our program who were using Kratom. We sort of figured out how much they were using. We started to give them Kratom. A lot of them stabilized. I think it says it's kind of hard to middle here, but between 8 and 16 milligrams. And so patients did really well transitioning from using Kratom onto Suboxone. They did well. Here's another just sort of case study from the Journal of Addiction Medicine. One of the things, and we'll talk about this as we go on, but how do you dose buprenorphine for a patient that's using Kratom? Because it's an unregulated thing. There's different potencies of it. Nobody really knows how much they're getting, although they may have a rough idea. And again, this study sort of concluded that patients that are using maybe less than 20 grams can be initiated on the agonist therapy. Probably would get around 4 to 8 milligrams, they would stabilize. And then as patients are using higher amounts above 40, sometimes 12 to 16 milligrams may be used. I like that I steal this from Dr. Massey. He talks about when we're treating patients for, pain or substance use disorder, sometimes we don't fully know if they're actually have a substance use disorder or not. But I think John says somewhere around like 4 milligrams is where you have a decent idea of like, hey, if people stabilize on 4, they maybe not be fully into like a use disorder, but if they're needing more than that up into like this 8, 16, 24, they maybe have transitioned to more of like what we would say a use disorder. And so again, those are sort of rough numbers, and John can correct me if I'm wrong when he gets a chance here at the end. Here's again, Kratom, or for Kratom, Narcan works to reverse this. So please make sure patients have this available to them. I put Kloxxado on there. That's just one of the newer Narcan sprays. It's essentially just a double dose. It's an 8 milligram instead of a 4 milligram. So that's also available. Here is another kind of quick tip guide. A lot of this stuff we've already gone over, but Kratom, can cause, at the bottom there, Kratom in pregnancy, it can cause neonatal abstinence syndrome, which again, Suboxone can cause neonatal abstinence syndrome. So patients who are, pregnant or going to be getting pregnant, we should let them know that the Suboxone can cause neonatal abstinence syndrome. A lot of times, as long as people know that the patient is on Suboxone, it's really well managed in the initial sort of hospitalization time. Breastfeeding can be helpful for that. It's probably a whole talk on that, so we won't sort of dive into that. But another slide for you, just for reference, if you want it. And then again, here's sort of the summary on Kratom. It's unregulated, it's addicting, it's got similar symptoms to opiate use disorder. Buprenorphine does work to treat Kratom use disorder. Overdose is rare, but you can use naloxone. Want to evaluate for lead toxicity. And then I think it's an interesting discussion. Maybe we don't have time for it today, obviously, but Kratom has been talked about as being sort of a harm reduction tool. And I can understand where that's coming from because, again, the risk of overdose is pretty low. Patients can transition to it if they are using harder drugs over to Kratom. But again, it's probably not the way to go for that. So, all right, I'm going to push pause here for a minute. We got about 20 minutes left in our time. Are there any questions that we need to go over? Or this would be a time if you want to speak up and ask questions or do a case study of your own, we can do that.
There are a couple of questions in the chat, and I think Janet answered those pretty well. I thought I'd just let you weigh in, Ed, if you had any other thoughts. Someone asked about drug testing for Kratom. It sounds like you have to order a specialized drug screen for that. Is that correct?
Yeah, that's a good question. So we have the ability to do like initial drug screening, which we call like presumptive, which just gives me a positive, negative on Kratom. Okay, let me rephrase that. I don't actually have the ability to do that where I am, but those tests do exist. So you can actually even like get on Amazon and order like Kratom urine drug screen testing. There's also like definitive tests that will show for Kratom. The problem is because like Kratom, I'm using the language of like Kratom use disorder. It's not really probably a real diagnosis. It's just like they've been using Kratom and it's probably opiate use disorder. We're saying that the Kratom is causing that. But when I was ordering drug screening for Kratom, I did get into some issues with insurance not paying for it. They were just saying like, hey, this isn't a real disease, or like the studies are not clear on if you need to do it or not. And so I got into a little bit of a back and forth with one of the insurance companies about trying to get that paid for. But yes, it's my understanding that both exist, but I would say the definitive may not get covered. Janet, is that where you landed too?
Yes, it is. I mean, it, for legal purposes and, research, it can certainly be detected, but it's not on our standard things by any means.
Yeah, not super common. Yeah. And again, that's a really good question, but it doesn't deter us from initiating someone on Suboxone, right? Like a lot of times, even if people come in and say they're using whatever drug, I never have a drug screen back on, well, I could have a presumptive, but generally speaking, like the way that it's set up, I don't have any drug screen back when I start someone on Suboxone. Like I'm still willing to start them, initiate them on them just based on what they're telling me. And then we'll try to get those results as we go. It's a good question.
There's one other question about the mechanism for creating the skin wounds with the xylazine. And Dr. Bernard gave the answer is vasoconstriction of blood vessels. And just pop that up, see if you have anything else to add to that.
Nope, yeah, that's exactly what I understand too. Yeah, there's a vasoconstriction component of that that causes the necrosis in those wounds to sort of open up. So that's excellent.
I don't see any other questions in the chat right now. Feel free to pop those in if you want to. I suppose, Ed, if you wanted to go through a case study, do that.
Yeah, so let's talk about, let's just dive into a couple of case studies on Kratom. And we'll just go through as many as we have. And yeah, trust that you'll jump in the chat if you have questions. So this is a 36-year-old male, presents with a 4-year history of Kratom use. Started out, recreationally from a friend. He currently reports to you that he's taken maybe 20 to 40 pills a day. Not exactly sure of the dose. Again, no medications or allergies, no significant abuse history. He does drink alcohol on the weekends, but he doesn't really feel like that's a significant problem for him. He reports that he's tried to stop multiple times, but can't get past sort of withdrawal symptoms. He does tell you, like, hey, withdrawal symptoms start about 12 hours after the last dose. And again, I think this is a relevant question as you're trying to talk to patients. I mentioned earlier, hey, we've gotten away from maybe the 24-hour mark and more saying like, hey, when you have symptomatic withdrawals is when you can start some of these medications. So again, for this guy, 12 hours, he starts to have some of the withdrawal symptoms. The way I approach this is I do the DSM-5 criteria for opiate use disorder, and I'm just sort of documenting that like, hey, Kratom is acting like an opiate. And so again, the DSM-5 criteria, it's pretty straightforward, but it's like, hey, has the Kratom gotten in the way of your life? Have you had any, physical issues from it? Have you developed withdrawals or tolerance? Has it, caused problems in your social life, things like that? So I do document that. Again, because they're not an FDA-approved medication, essentially, we do recommend the motivational interviewing and contingency counseling, and then would transition to Suboxone. So I mentioned earlier in the slides, the dose equivalents are a little bit difficult, but I would say if people are just using like leaves or teas, like it would probably go, those are the least potent, followed by pills, followed by liquids. So when patients like tell me the progression of what they've used, usually the liquid is the most potent. So this guy's using pills, so he's kind of right in the middle. Again, the half-life is believed to be relatively short, but it does stay in the urine drug screens for up to 2 to 4 weeks. And so what I would generally do for this patient is just start with sort of a conventional induction at the 24-hour mark about, would provide some withdrawal medications, maybe the Zofran, the Clonidine, and the hydroxyzine. Again, this is just sort of a re-picture of the slide from before, but just to highlight, hey, we wait to 24 hours and then you don't have to start with 2 milligrams. You can start with less, but every 2 to 4 hours, you can increase that. Here's just another slide for you on the withdrawal medications that we can use. All right, so, oh yeah, the drug screening thing, we put it in here. So, first appointment, it can be on presumptive testing, but definitive is also available, may not be reimbursed. So generally, when I see these patients, I do try to see them back like within probably 7 to 10 days. And there's a couple of reasons behind that. Mainly, I want them to have the Suboxone and have enough time for them to have it build up in their system, because the medication does take about 7 to 10 days to really fully build up in their system. I often don't have any drug screen results from my initial appointment. So if I see patients back sooner, it can make it a little bit more difficult to sort of know what's going on. So this guy comes back, we'll say 7 to 10 days later, and he's not using Kratom. He is still reporting cravings, not having any significant withdrawals, and he is dosing the Suboxone approximately 3 times a day. So again, my plan initially with him was like start him somewhere around 12 milligrams a day. With the conventional initiation, as you start patients on that, like they're taking small amounts of Suboxone like every hour or 2 hours, right? And so a lot of times, even if you tell the patient, hey, after the first day, I just want you to take the medication once a day or maybe twice a day, you'll often see them coming back taking it multiple times a day again, which is fine. It's not dangerous or anything like that. But he's still taking it 3 times a day. And so he's having kratoms, and so what are cravings? And so what we did in this guy, like, just want you to know, like, if patients are reporting cravings for a substance use disorder, that's a totally legitimate reason to go up on their dose, even if they're not having withdrawals. If they are reporting cravings, mild, moderate, severe, that's a reason we can go up on their dose. So what I did for this guy is we increased his dose to 16 milligrams, and I try to tell patients, hey, I want you to have a goal of taking the medication once a day or twice a day. About 50% of my patients prefer twice a day dosing. The medication is really designed to be taken once a day, but a lot of times people do like to take it twice a day. And the other thing I try to tell patients in those situations is like, hey, the reason I want you to take the medicine twice a day is because you have been in a habit of taking kratom multiple times a day. You're taking 20 to 40 pills a day. I assume that's throughout the day. And so we want to get them out of a mindset of trying to use a substance whenever they feel something or whether there's some sort of stress or whatever. So we're trying to say, hey, you pick a time twice a day, take it no matter what. And then in between there, just know the medication is working. Let's try to figure out different ways to deal with whatever's happening. And so I really do try to encourage patients max of twice a day dosing, unless we're dealing with patients that have some sort of like pain issues. All right, any questions on that one? I got one more for you before we shut it down for the day.
We got a couple questions in the chat. Maybe it makes sense to do those quick. Is that okay?
Yep.
Okay, so let's see. This one from Hamet. If a patient is on a tricyclic antidepressant for pain or behavioral health, then would it interact and show up if they test for Tianeptine?
I don't know. I honestly, I don't even, Tianeptine is so rare for us. I don't even know that I've actually seen a drug screen where we've tested specifically for it. So I will be honest, I do not know the answer to that question. Any other of the experts want to chime in on that?
Stephanie or Todd?
Typically, you have to check for Tianeptine. It does not show up as because the structure is a tricyclic, but it's atypical that it usually won't show up on a drug screen unless you're looking for it specifically. I'm not sure I'm answering the question or completely understand the question that's in the chat. Remember, it's used as an antidepressant in many other parts of the world, right? So, and it's also got opioid agonist effects, and so it's somewhat of a unique drug. That's why it's sometimes called an atypical tricyclic.
Great.
It's like some of the old heterocyclic antidepressants that are not used much anymore.
Thank you. That answered the question. We had one. I don't know if John's still on. I know he had to get over somewhere else today. Janet did give an answer to this question. Question from Clinton: is it appropriate to start buprenorphine for chronic pain when the patient is not on medicine opiates?
Yeah, I don't know if John is still on, but I think there's a lot of interest in at least the pain management side of looking at that instead of going down that road of primarily opiates, especially for people who are going to need pain medicine long term. Because with opiates, you're going to be developing tolerance and increasing dose requirements, and you do not need that with the buprenorphine. Now, if someone sprains their ankle, do they need buprenorphine right then? I don't know. Certainly, I think it's preferable to not use opiates at all in those situations if possible. But I think there's a lot of interest in looking at buprenorphine use primarily now for people who are going to need longer-term pain control.
Yeah, I agree. I think it's a fascinating thing that's coming up. Suboxone is going to be really helpful for pain.
See any other questions? We've got 10 minutes, Ed.
Yeah, I'll run through this last one together and then we'll get you guys out of here on time. So this is we'll pick on the girls this time. 34-year-old female, says that she's been taking 2 to 4 tablets per day of the Kratom. So she was prescribed tramadol in the past by her doctor and sort of has the sort of normal story of getting cut off. And she ended up finding Kratom and getting started on that. She's tried to stop in the past, has had some success, usually goes back within a week or two. Generally, this patient can go 24 hours without using Kratom before she's starting to feel sort of the withdrawals, nausea, body aches, insomnia. So she is on prescribed clonazepam, 0.5 milligrams twice a day is needed for anxiety, maybe some birth control, antidepressants, pick whichever ones you want. Again, just a reminder on the benzodiazepines. Hey, Suboxone and benzos can cause increased sedation, but it should not be a reason to not start someone on Suboxone. And clonazepam, if you had to pick a benzodiazepine, is probably the safest just because it's a long-acting one. So no medical allergies. Again, did some DSM-5 criteria, talked about a conventional induction with a target doses much lower for this patient. We're going to say 2 milligrams. So again, we can start with like a 2 milligram strip, cut that down into like quarters or even smaller. So they can start with a 0.5 milligram, take that sort of every, hour, hour and a half. And this patient, she's real nervous about starting on Suboxone, not really familiar with it, hasn't been around it before. So she wants to come back, and we end up seeing her back in the clinic, we'll say 4 days later. So she came in on a Monday, coming back on a Thursday or Friday. So she comes in and she's not doing great. She is reporting nausea and cravings. So her last dose of Kratom was on Monday when we initially saw her. She did start the Suboxone somewhere around Tuesday morning. She eventually got up to taking like 1 milligram twice a day. So she did the conventional, but not quite as small, started with 1 milligram. Says that it went okay for the first day, maybe some mild nausea. And then the second day, she started getting more nauseated. Again, she's not sure if the medication or the withdrawals is causing the nausea. The nausea throughout the day did end up having a couple times of emesis. And then the problem here is she also reports that when she has her first symptoms of withdrawal from the Kratom, it's nausea. And so that can also be like a helpful tool as you're talking to patients, like, am I in withdrawals or am I having side effects from this? Like, what symptom do you generally feel first with your withdrawal symptoms? And so for her, it's the nausea. And so today's day 4, okay, no Kratom use. Day 3 of Suboxone, she's taken 1 milligram so far when she comes and sees you in the clinic that day, and it was about 2 hours ago. She does not report that she's feeling like overly sedated or high on the medication, so it's not making her overly sleepy. So this is the second visit, and I give you this case study just to say, I don't know what's going on with this patient exactly at this point. Okay, so it's not always just like this straightforward, oh, this is simple, this is what's going on. She could be having withdrawals, okay, because she's a few days out of no Kratom, and sometimes that can take a little bit longer for that to kick in. She very likely could be having side effects of Suboxone, and she is still having cravings and desire to use Kratom. So again, just the reminders on this, it does take about 7 to 10 days for the medicine to build up in the system. Definitely want to review sort of proper dosing with this patient. Again, the medicine is absorbed in your mouth, and so no part of the medicine that you swallow gets significantly absorbed into the body. So making sure the patient is not eating, drinking, smoking, vaping before and after dosing. I did have the patient start taking some Zofran probably 30 minutes before dosing. I think this can be really helpful because one of the most common side effects is like nausea and headache and stuff with that. So give them some Zofran 30 minutes before, have them take the medication. And again, at this point, I just have the conversation with the patient like, hey, the dose may be a little bit high because you weren't using a lot, and that could be why you're having side effects, or maybe the dose is still a little bit low and needs some time to build up in the system. So what I did for the patient is I said this, hey, I'm going to prescribe you up to 2 milligrams twice a day, which I think just based on my experience with Kratom and the amount she's using should be plenty of Suboxone for her. So you can take up to that amount. Pay attention to when you're getting nauseated because the medication does sort of peak in your system 2 to 4 hours after dosing. And generally, like the nausea, headache, common side effects are going to get better with time over the course of about a week. I also told the patient, hey, it's okay for you to take less. You can even cut that thing down. You took a 1 milligram the first time you took it. You can cut it down and take a half a milligram twice per day, or you can maybe try 1 milligram like 3 times a day and try to figure out where it's at. But the max dose I wanted for this patient, again, it's day 4, so I don't fully know what's going on. I don't have my drug screen back, but the max dose I want to start her on is maybe like 2 milligrams twice a day. So eventually this patient, what she ended up doing, she came back a week later, she did stabilize closer to taking 2 milligrams in the morning and then 1 milligram in the afternoon. So around 3 milligrams of Suboxone. She did continue the Zofran prior to dosing for a couple of weeks. Her cravings were well controlled. She had minimal side effects of the medication as time went on. And so she ended up doing pretty well. But again, my whole point in putting that case study in there is just to say, hey, the picture is not always super clear, especially if we're seeing patients right away, because sometimes there's side effects and sometimes there's withdrawals that go into it that are sort of coinciding. But really encouraging patients to take the medication appropriately and then just to give it time and it'll sort of like play out. The other thing in this patient situation that made it more complicated, which you probably see in your own practice too, is like the patient comes in on a Monday, but she's working a full-time job, she has kids, and she doesn't have time to like take 4 days off and like stop her kratom and just really like take it easy. She's like trying to go to work, trying to take her medicine at work, trying to like figure this out, getting sick, back and forth. And so again, in a perfect world, if she had a 3 or 4 day weekend to try to figure this out, that would probably be better. The other thing I'll just say about this is, she was using tramadol, and I saw a patient the other day that was prescribed tramadol or was abusing tramadol, I guess. And I overdosed her on Suboxone, meaning I prescribed her too much Suboxone for what she was taking. I think I prescribed her like 4 or 8. And the patient comes back a week later and she's like, I was throwing up, I was vomiting, I was having like a side effects of the medication. And so my encouragement in that is just like, hey, like you can give these patients medication. If it's too much medication, they're likely going to have side effects and they're going to back off on their own. And so just telling them like, hey, I think it's going to be around here, but you can take less. And so again, I always want patients to have enough medication, but we're not trying to short them, but just tell them that they can take less and they'll do okay. So
a thing I would add is that it is so important to be available to your patients, even maybe by phone or through messaging at first, because it's not difficult, but it does take a little bit of adjustment. And really, if you that first 7 to 10 days is kind of the, once they get settled down on their dose, it is no problem. But it is really important to be available and be listening to messages, and you can make some of those adjustments on the fly and help them do a whole lot better on it.
I do agree with that, Janet. And I'm probably speaking out of my own experiences. Like I have a nurse care team that fields all those phone calls for me, right? So again, it probably is good, especially if somebody's brand new to it, to maybe touch base with them sooner. Absolutely. I agree.
And last, I just want to jump in and add a little bit. This question was already answered, but I just want to add a little bit more on the buprenorphine regarding pain, not on legacy opioids. The answer is absolutely yes. It's approved both for acute and chronic, and I frequently get consulted on inpatient units in the hospital for starting this because if they were on it before and their legacy opioids did not work. Buprenorphine generally works a lot better with less side effects. So I just want to make sure I got that question answered.
All right. Thank you, everybody. Thanks, Ed. Great talk as always. It's like we're about at the end of our hour here. So I just want to put in another reminder for our little consult line. The best way, again, is to just contact me. And if you're getting my emails, all my contact information is in that email. You can call me, text me, email me, however you prefer to contact me. And then I can hook you up with the appropriate expert to answer your questions and hopefully help you treat your patients. Again, we'll be off for a month here. We'll be back on July 12th. So keep an eye out for some registration stuff for that next series of trainings. And again, you can register for that next series in this evaluation survey, which I said is in the chat, and will also come out later. So thank you, everyone, and have a good day.
Good job, Ed.
Thanks, Janet.